Hello, and welcome to CDCES's podcast, The Huddle, Conversations with the Diabetes Care Team. In each episode, we speak with guests from across the diabetes care space to bring you perspectives, issues, and updates that elevate your role, inform your practice, and ignite your passion. I'm Jodi Lavin Tompkins, Director of Accreditation and Content Development at the Association of Diabetes Care and Education Specialists. My guest today is Gary Rothenberg. He's a clinical associate professor of internal medicine and vascular surgery at the University of Michigan School of Medicine. He's also the fellowship director, limb preservation research at the University of Michigan, and a podiatrist, certified diabetes care and education specialist, and certified wound specialist. In this episode, we're going to have a conversation with Gary about diabetes-related peripheral neuropathy, and the pain that comes with that. And I especially am happy to have him here because I thought it was important to have the podiatrist perspective, especially one like Gary, who's also a CDCES. So welcome to the Huddle, Gary.
Thanks so much for having me, Jodi. I'm appreciative for the opportunity to speak with you and engage with the listeners.
Yeah, so before we dive in, I'm wondering if there's anything more you'd like to share with our listeners about your background or your experience as it relates to today's topic.
I've been a practicing podiatrist for about 25 years now, and I really want to focus and talk with your audience about how neuropathy is at the core, at the root of, unfortunately, a lot of problems that people living with diabetes can experience. We know that neuropathy is on the front end of developing sores and diabetes-related foot wounds, which unfortunately can lead to hospitalizations and even subsequent amputations. So a discussion around neuropathy is really important, and I'm glad to have that with you today.
Let's get into the topic then. How common is diabetes-related peripheral neuropathy, and how is it diagnosed?
Yeah, great question. I always think it's important to remind people that nerves have two functions. We mostly think of them in terms of the sensory component, and that's the burning, tingling, pins and needles, numbness, or I've even heard unusual things from my patients, like it feels like my socks are wadded up in my shoes and I look at them and they're not. Or another common one that I hear is it feels like I'm walking on bubble wrap. So anything unusual like that is the sensory function of a nerve. But I also will remind the listeners, motor function is dependent on nerves as well. So unfortunately, when people develop diabetes-related peripheral neuropathy, it can manifest in terms of muscle weakness. So typically, patients with diabetes can develop hammer toes or claw toes, where there's muscle wasting from the neuropathy process, and they end up at risk for falls, which is obviously, as we know, a very devastating potential event. So I remind the listeners again that it's also important to do a musculoskeletal examination in addition to that neurologic examination, where we're looking at people's feet to assess, is there a muscular component to their neuropathy as well? Again, that would be hammer toes, muscle wasting, risk of falls or history of falls. Those are also kind of some other symptoms or manifestations of diabetes-related peripheral neuropathy. The truth is that, unfortunately, diabetes-related neuropathy may be the reason that people are actually diagnosed with diabetes. Maybe a patient has symptoms including numbness or tingling, burning sensation in their feet, and that prompts them to actually go see their healthcare provider. So what the literature will tell us is that people living with type 2 diabetes, they will experience the symptoms of diabetes-related neuropathy sooner than people with type 1 diabetes. On average, people with type 1 diabetes may develop these symptoms around 10 years into their journey of living with diabetes. Now, diagnosis is generally through symptoms, and the most common symptoms are what I mentioned before: burning, tingling, pins and needles, or numbness in the feet. There are, of course, objective ways to diagnose diabetes-related neuropathy. A comprehensive neurologic exam performed by your healthcare provider It will generally involve something called a Semmes-Weinstein monofilament. Your listeners may be familiar with the small monofilament. Kind of looks like a fishing wire, and that determines what we in the field call protective sensation. So your healthcare provider will test that little monofilament on multiple sites on the bottom of the patient's foot. And if they feel that monofilament, it's a slight sensation, but if it's felt in 6 out of 10 sites or more on the bottom of the foot, then we call that protective sensation intact. In other words, I always tell my patients, if I'm worried about you with symptoms of neuropathy and a carpet tack should come loose in your home and you were walking barefoot, which patients with diabetes should not be doing, but if they were to walk barefoot and step on that carpet tack that came loose, would they feel it? That's called protective sensation. There are several other objective tests that a healthcare provider may perform, like a tuning fork test for vibration, a sharp dull test to see can the patient differentiate between sharp and dull or cold and warm. So to answer your question, it's a combination of objective and subjective symptomatology that will give a diagnosis of diabetes-related neuropathy.
Okay, well, pain, I know, goes along with this diagnosis, and in addition to some of the other symptoms you mentioned. And I think, pain is different for everyone. What do your patients tell you? In other words, how did they describe this for them, their
Yes,
experience?
very good point. And yes, pain is different for everyone. Some people may call it a discomfort or an awareness. But when people mention pain to me, usually it is described very sharp. Again, a burning sensation. That's very common with diabetes related neuropathy. And these symptoms are more prevalent at night. And that is a common factor and a common denominator in what I would refer to as symptomatic diabetes related neuropathy. Some people, unfortunately, they lose all sensation. And while they're aware of this numbness, it's not pain, as you're kind of alluding to and pointing out. But the painful part of it is generally burning pain, very sharp pain that's worse at night.
So, if it progresses to that loss of protective sensation, how do you assess where they are in the progression? Is there a way to tell when they just go from a certain amount of pain to the loss of protective sensation? Is there a predictable progression?
It is progressive, as you're mentioning. And typically, unfortunately, people lose that gift of pain. And I had a professor in school that truly said, in this patient population, pain is a gift.
Hmm.
Nobody wants pain, but your body is talking to you and making you aware. In our patients with diabetes, one of the common factors may be that their blood sugars are above target. And their manifestation of that is then going to be this neuropathy type pain in their feet. So that's actually feedback that's really helpful to our healthcare providers is when are those symptoms present? Because maybe some medication adjustment needs to be done. But it is a progressive process that usually goes from painful to painless.
Hmm.
And while it sounds good not to have pain, again, that's what puts people with diabetes at risk for stepping on that carpet tack that I gave the example of a few minutes ago and not feeling it. And of course, that could create an open wound, an opening between the outside world and the inside world, and that becomes infected. And that's a problem because now, again, the patients don't have feeling and they allow that infection to progress. So it is a progressive state, and end stage is usually that loss of protective sensation where they don't have any pain or any significant feedback and the feet are truly numb.
And that's not reversible?
Generally, we don't think that diabetes related neuropathy symptoms or the gift of being able to feel that pain that you can give it back. The one thing that we do know is blood glucose levels in target range will help delay the progression of that ultimate result. So the mainstay treatment for diabetes related neuropathy is always going to be, and I have this conversation with my patients all the time, and I acknowledge how hard it is. But if it's more incentive and motivation to get their blood sugars in target range, because we can reduce the symptoms and reduce the probability of progression of that diabetes related neuropathy, then I on board with my patients to help motivate them in that way.
Yeah, that sounds like a good plan and maybe motivating for some people. You touched on treatment, and I wonder if you could talk more about that. So, what's the pharmacologic and non pharmacologic treatment options? And is there any evidence that they work? Tell us what's the most effective to maybe the least effective, that kind of thing.
Sure. I kind of think of the treatment for diabetes related peripheral neuropathy kind of as a pyramid. At the base of the pyramid, we're going to do the things that we know are always helpful. And those are the typical lifestyle interventions, making sure that patients are exercising so that the circulation is appropriate. Because at the core, also, we believe part of the etiology, the reason why people develop neuropathy is because the nerves in the feet are actually starved of the oxygen and nutrients that they need to survive. So exercise is a great option and, of course, recommendation for people to keep that blood circulating and feed the nerves the good oxygen and nutrients that they need. I mentioned trying really hard to get those blood sugars in target range. That's super important, and that's at the base of the pyramid. Making sure that patients are receiving good education and appropriate foot screenings. Usually that's with their podiatrist and following American Diabetes Association guidelines of annual foot screenings for everyone living with diabetes. That's at minimum. Those types of things, daily foot checks, making sure that patients are engaged in their own healthcare and looking for nuanced changes that are occurring overnight, new areas of redness or bumps or bruises or blisters or things like that. So that's at the base of the pyramid, I would say, is things that the certified diabetes care and education specialists listening today are very well aware of and what we do every day with our patient population. In terms of the next level up for treatment of symptomatic peripheral neuropathy, generally we go to the topical medicines, and these can be either prescription medications and or over-the-counter preparations that may be helpful. And I always look at these as kind of like a why not, because many of the topicals, they have minimal side effects. Of course, you could get some skin irritation from being maybe allergic to some sort of component in a topical medicine. But in general, patients tolerate topical creams and lotions pretty well. And there are ones that are more oriented towards nerve type pain. So typically some of the lidocaine-based creams or ointments, those that have lidocaine in them, obviously an anesthetic in a topical form, can be helpful. There are other products that are still by prescription topically, which may be helpful as well. There are newer things on the market, as we see in various parts of the country where patients have access to CBD oils and creams, things like that. We find some of our patients are utilizing those, and they may be helpful for painful peripheral neuropathy. Other over-the-counter preparations, a lot of these pain relieving balms. Some of them, again, can be very, very helpful. Then once patients kind of plateau or they don't find topicals as effective, then of course there are the oral medications. Oral medicines generally are prescribed to people, again, who have symptomatic peripheral neuropathy that's interfering with their sleep cycle. As I mentioned, many of the symptoms are more prevalent at night. And so interrupting people's sleep cycle is really disturbing, and it can be a significant quality of life impairment. So many of the oral medications are geared at calming down the nerves. So probably the most commonly prescribed oral medicine is gabapentin or Neurontin, very common for peripheral neuropathy. And again, the usual dose, we start off at night. It has a mild sedative effect. So patients that have interference with their sleep cycle, they generally receive a benefit from that gabapentin. There are actually only 3 FDA approved oral medicines for peripheral neuropathy. The interesting part is that many of the oral medicines that are recommended for painful or symptomatic diabetes related peripheral neuropathy are actually used off label. Even, in fact, gabapentin is. Other medications from the mental health space are often utilized for painful neuropathy as well. So we have to be careful, and healthcare providers obviously have significant discussions with their patients about the side effects, the risks, and the benefits of the oral medicines. Interestingly, there are some advances in topical procedure-based treatments for diabetes-related peripheral neuropathy. That topical that I mentioned, one of the topicals is capsaicin. There's now a procedure that's done in a healthcare provider's office where a very high dose of capsaicin is administered to the patient's feet. In the clinic, they have to be monitored because it can actually cause blood pressure issues. But again, a topical medicine in a procedure form. And in very extreme cases, there are surgical releases of the nerves that can help benefit people with symptomatic diabetes-related peripheral neuropathy. So a long answer because there's so many options and so many choices. And again, I kind of look at it like a pyramid, and we kind of work up that pyramid and hope that there's improvement along the way.
Now, I've heard of spinal cord stimulators, and I think they're implantable. So, where do those come in?
Those are definitely at the top of the pyramid. Again, I would say that's one of the advances I was kind of alluding to, but those are really for patients who have exhausted everything else. As you can imagine, an invasive procedure, implanting a foreign object or the spinal cord stimulator into a patient, for somebody who has maxed out on the oral medicines, not receiving any relief, and having very symptomatic quality of life impairment, things like spinal cord stimulators are showing promise. Generally, those are done, of course, by pain management specialists. So, the people who may be involved in managing this, I'm a bit biased, of course. I'm a podiatrist. We tend to be on the front line of helping patients manage their diabetes-related neuropathy, but certainly other healthcare providers, diabetes educators, and pain specialists, neurologists, those are some of the other healthcare providers who may be involved in managing this problem.
Okay, well, you've covered a lot of ground here. So, what can we do to communicate best practices? But also, how can we support them with their self care and coping with this condition?
Yeah, I think it's a great question. Again, very biased. Have a long-standing relationship and appreciation for the role of the diabetes care and education specialist. I know that they are so involved with education, and I believe that's the core of what we need to do with these patients is educate and support them, make them aware of the potential symptoms, what to look for, really stress daily self foot exams. And it's interesting because I was classically taught as a podiatrist, hey, tell my patients with diabetes, look at your feet every day. Well, my practice has actually changed over the years because we also recognize that people with diabetes are at risk for retinopathy and eye disease. So that old mantra of have your patient look at his or her feet, it may not work so well because of mobility issues, because of obesity. People, I think in general, have a hard time seeing, especially the bottom of their feet. So I think we strategize and we work with our patients to educate them and reinforce that the early front end detection of problems is going to be much easier to manage than waiting until, unfortunately, the feet completely go numb. So I think stressing daily self-exams, which I've moved to a more tactile approach. So, of course, I still recommend, if patients can, to look at their feet every day, but I also recommend that they touch their feet every day. If they can, use a good skin cream or lotion. And I've decided I don't care what cream or lotion patients use, just that they use something frequently, but I ask them to do a 2-for-1. Touch your feet every day, rub a little bit of cream or lotion, avoiding the interspaces. But really what they're doing is a daily self-exam by touching their feet. So I would encourage all of my CDCES colleagues to make sure they're educating patients about daily self-exams, as well as the signs and symptoms of neuropathy. And of course, what they do best is help come up with their plans for appropriate empowerment and working with them to get their blood sugars in target range, which in particular for neuropathy is a huge advantage.
Okay. I'm wondering if there are specific resources that you could recommend if people want to learn more or find out more information.
Sure. Of course, there are wonderful online resources, the American Diabetes Association, and following their best practice guidelines, whether it's for us as healthcare providers or as patient resources. There's, of course, the American Diabetes Association. The American Podiatric Medical Association is another wonderful resource. That's our parent organization within podiatry. And there are many patient-friendly online resources as well that can be accessed through that website. And another great resource that we have for your listeners is a tip sheet that ADCES has prepared regarding this topic, and it will also be included in the show notes.
Great. Gary, thank you so much for taking the time to join us for this episode of The Huddle and for sharing your expertise on this topic.
Thanks so much, Jodi, for having me. I appreciate the opportunity and really everyone's efforts towards prevention of lower extremity complications among people living with diabetes. That's our goal.
I want to take a moment to thank Lexicon for their support of this podcast. And thank all of you for listening to this week's episode of The Huddle. Make sure to download the resources discussed in today's episode. You can find them linked in the show notes at adces.org/podcast. And remember, ADCES membership gets you free access to resources, education, and networking that improve your practice and optimize outcomes for your clients. Learn more about what ADCES can do for you at adces.org/join. The information in this podcast is for informational purposes only and may not be appropriate or applicable to your individual circumstances. This podcast does not provide medical or professional advice and is not a substitute for consultation with a healthcare professional. Please consult your healthcare professional for any medical questions.